platform. It is a wonderful occasion that you are together in doing a great work under the leadership of our President Dr. Neelama Madam. A vision of having this program is a wonderful initiative, and also she brought a PG teaching program, intensive coaching clinical program, which also went on recently, ably supported by our dynamic SSG Ruchira ma'am and all the stalwarts, my good friends are Srinivasan sir and MSV and all others who are in the platform. Today's teacher, mentor, whatnot, our good friend who have been associated with her for so many decades. And our Santilal orator recently have been awarded one of the very prestigious oration, though she got lot of orations in her credit, but our IAP oration credit, which is got only one, she received last year, which was a wonderful moment to witness it. Hats off to ma'am. And they say not far of that, you will achieve many more laurels. Your commitment and towards nutrition and developing how you are dedicated for not only teaching of your postgraduate and the entire community of India, which you are doing. And Kirtana, I think you are blessed to have Madam with you today as your mentor, and all those who are joined here definitely will be beneficial. And our convener and mentor of all our SBSR also have joined now. And I hats off to Ganesh Kulkarni and his entire team doing a good work in Digi Academy. With this, I wish you all a happy learning to all of you. Thank you, Ramakrishna sir, doing a extraordinarily great work. Please continue the work for the benefit of our postgraduate. In turn, we do a good work for our community. Over to you, sir. Thank you, sir.
Thank you very much, sir. Our Honorary Secretary General, Dr. Ruchira Gupta. A few words.
Good evening, everyone, all the respected dignitaries over here. To mention Dr. Ramakrishna, Dr. Neelam Madam, who's just now, who was here, our President-elect Dr. Singravelu sir, Bala Subramaniam sir, our mentor, and Dr. K. Elizabeth ma'am, today's mentor and mentor to me also. And Dr. Ramakrishna Paramahansa sir, this program is being, you all are enjoying or rather learning from this program because of him, because he's so persistent. Every time he's bringing one or other legend, and with the advisory of Bala Subramaniam sir, no doubt about it, that there is icing on cake. If I talk, whatever Singravelu sir said, I 100% concur with him. And when it is Elizabeth Madam, what to say? My heart is totally, what should say, is thrilled with the excitement to listen to her, because I know she's excellent orator, she's excellent academician, excellent teacher, and above all, she's excellent human being. So, Kirtana, as sir has said, you are blessed to have her. We all love her like anything. So, we all wish you a happy learning to all of you. Over to you, sir. Thank you very much.
Thank you, ma'am. Dr. Ganesh Kulkarni is with us. Dr. Ganesh Kulkarni. So, then, okay. I think we can go ahead. Dr. Singravelu sir, we will go ahead with the academics. Right, sir?
Yes, sir. Yes,
Right.
sir.
Right. And
anything from SBSR, then you can, if you want.
no, Dr. SBSC is reserved for academics. Dr. Elizabeth, Dr. SBSC, they are reserved totally for academics. Right, sir? Am I right, Dr. Bala? Others will say.
Yeah, thank you. Thank you very much. Please go ahead.
Right, sir. Now, I request Professor K. Elizabeth to enlighten us, enrich us with her experience, expertise, teaching skills, and she doesn't require any introduction because she had been with us for more than 4 decades. She is an author of textbook on nutrition. She received multiple oration awards, and she is a senior most professor and one of the very few who are very much adept with the nutrition and nutritional diseases. Ma'am, please take over. And Dr. Kirtana, I wish you all the best and be assertive, confident. We are here to encourage. Suppose some questions are asked, it's only for bringing out the best from you and your mentor, Professor Elizabeth. Not to criticize, not to prevent or inhibit you. Okay, take it in a right way. Ma'am, Professor Elizabeth, you may take the stage and Dr. Ketna will be presenting the case. Dr. Ketna, just you share the screen once.
Thank you very much for your kind words. I place on record great appreciation for the team, Dr. Neelam Mohan, Dr. Singaravelu, Dr. Rujira, Dr. Ramakrishna, and all our senior IAPNs who have come, Srinivasan sir, Balasubramanian sir, and I can see a lot of youngsters also. We have taken a very we have taken a prototype case.
Good evening, Dr. Delphine. I am Dr. Singaravelu. Dr. Singaravelu. Good evening. Fine. Very happy to. I heard that you were gem. So
Yes. Make it full screen, Dr. Ketna. Yes. Make it full screen, Dr. Ketna. Full screen. Yes. PPT is visible. PPT is visible.
Yeah. So we have taken a prototype case. Of malnutrition. Yeah, some echo is there. I don't know why. Okay, Kirtana. Best wishes.
I think someone might have
you can
joined from
present.
two devices. Someone might have joined from two devices. I mean, the person who has joined from two devices. The person will have to log off from one device. Will have to log off from one device.
From one device, right. From one device, right.
Dr. Kirtana, you can
Yes.
present. Dr. Kirtana, you can
Yes.
present. Are you mute? Dr. Kirtana? Your screen is not visible.
Dr. Kirtana, you please unmute yourself.
Your screen is not visible.
Be cool. Yes. Be cool.
Yeah.
Right. Yes.
Yeah.
Right. Make it full screen.
We can't hear you.
Please unmute Dr. Kirtana.
Ma'am, you may call her.
Sure. കീർത്തന കേൾക്കാൻ മേല സ്ക്രീനും കാണാൻ മേല
അൺമ്യൂട്ട് അത് മാറുന്നില്ല മാം.
Can the host help her? Yeah. Now you are.
Now you are audible.
Yes. You unmute yourself. Dr. Ketana, please unmute. Okay. Dr. Ketana, you are muted. Yes, muted. Right. Come on. Yes. Right. Come on.
Can the host help?
Unmute, doctor. Now you
Can
are.
the host help?
Unmute, doctor. Now you are.
Ma'am, you need to unmute yourself. Ma'am, you need to unmute yourself.
Just click on that speaker's phone's right. Just click on that speaker's phone's right. Yes.
Please speak, Dr. Kirtana. Let us see.
Hello, ma'am.
Yeah.
Yes.
Am I audible?
Fine.
Yeah, you
Fine.
are audible
Everything is
now.
Fine. You go ahead.
Please share the screen and present. You are audible. Good. Or can you give me the link? I can share.
Okay.
Now your screen is visible.
Am I
Make
audible,
it,
ma'am?
yeah, you are audible. Your screen
Okay.
is visible. Make it full screen and present.
Yes, ma'am. So good evening.
Full
Sorry for the
screen.
delay.
Full screen.
It's full screen. It's on full screen, ma'am.
Okay. We'll carry on like this.
So a 15-month-old female child named Navya, informant being mother, was reliable, came with complaints of not gaining weight for last 6 months, noted from the 9th month of age, and
Your
with
screen is
swelling
not
of
moving. Yeah.
child. Go with.
Yeah.
And came with complaints of swelling of bilateral hands and feet for 15 days and fever and loose stools for 3 days. And child was apparently normal 6 months back, and mother noticed that the child was not gaining weight as compared to her peers. And poor weight gain was first noticed at 9th month of age during a routine immunization visit. And that there was history of bilateral swelling of both hands and feet for 15 days, which was insidious in onset and limited to bilateral wrist and ankle with no diurnal variation or puffiness of eyes. An history of fever for last 3 days, which was intermittent and low grade, which was relieved on taking over-the-counter medications. Shall I proceed, ma'am?
Yes.
Proceed. See,
Yes.
till somebody stops, you continue to present. Okay.
Continue.
Okay, sir. Child also had loose stools for the last 3 days, 7 to 8 episodes per day, watery, large quantity, and loose stools were present during night time while she was asleep and after feeds with history of perianal excoriation. There was no history of tenesmus, blood, or mucus in stools, and child
Now
is
you
irritable.
hold it
and
here. Hold it here. So
Yes, ma'am.
what type of diarrhea you are postulating here? Because you have given some
Mostly-
information.
Yes, ma'am. Mostly osmotic diarrhea because it is during night also.
No. Watery
So,
diarrhea.
sorry, ma'am, secretory
Yes.
diarrhea.
So
Watery diarrhea due to
it's a
small
watery
intestine.
diarrhea. What do you think is the site of involvement? It's a small bowel
Probably
diarrhea
small
or a large
intestine.
bowel?
Small bowel.
Small bowel. What are the two
Yes.
types of watery diarrheas that we usually encounter? Yeah, you said one. You said both,
Osmotic and secretory.
which is by far more common.
Os-
Osmotic.
Osmotic, ma'am.
So osmotic diarrhea presents in relation to feeds, no?
Only after
Osmotically
in relation
active
to feeds.
particles are there. Okay. And the other secretory diarrhea presents when? Irrespective of
It does not depend
food
on the
intake,
feed
whether
or
starving, on IV fluid, sleeping, etc. So you are postulating that there is both osmotic as well as secretory diarrhea. Okay. And perianal excoriation is in favor of which one?
Can be a lactose intolerance
That is which type of
or
diarrhea? Osmotic diarrhea.
osmotic diet.
Osmotically active particles are
Os-
there. And
Yes, ma'am.
lactose is the main feed of a if the main content of the breast milk. Okay. So which condition can cause both? Usually we speak about either osmotic diarrhea or secretory diarrhea. So here both are there. So what may be the condition?
The questions posed are not just for Dr. Kirtana. I
Yeah.
wish many
can-
postgraduates to type in the chat box.
Can
and
type
if
in
you
the
want
chat
to
box also.
speak, you may unmute and speak. It is for you.
What is
Right.
the most common agent that causes diarrhea in infants?
Rotavirus, ma'am.
Yeah.
Rotavirus, ma'am.
Yeah. Rotavirus is well known to produce both secretory as well as osmotic because it damages the intestinal epithelium, and so there will be absorptive defect, and it also produces enterotoxins, toxin that causes secretory diarrhea also. So this is it. But most of our children are rotavirus vaccinated. What percentage of protection is there from our rotavirus oral vaccine? Is it a highly effective vaccine or moderately effective? Because measles, we say 95% protection. So what is the
Moderately effective.
70% they say. So, but the severe forms will be less. Diarrheal deaths can be prevented because severe diarrhea will not come. Like COVID and all, when we took, the severe forms will be less, but we may sometimes get it. That's it. Okay.
Okay.
So tenesmus, blood and mucus in stool is seen in what type of diarrhea?
In case of large bowel diarrhea,
That is invasive diarrhea. It causes
invasive.
colitis, ulcers, etc. Okay. We'll proceed because we have a lot more to discuss.
Okay, ma'am. So child is irritable and crying, drinks water eagerly with reduced urine output to two times per day, which was previously 5 to 6 times per day, and history of decreased food intake, and there was no history of vomiting. The child was given home remedies and was reported to hospital on third day of fever and loose stools.
So what is your
There were no history of
assumption about dehydration in this child from the history? Dehydration in this child.
Ma'am, since child is irritable and some dehydration, ma'am.
Okay. Drinking eagerly. Okay.
Drinking eagerly.
Good. Proceed.
So no history of passing worms in stools and no history of greasy or bulky stools or regurgitation of feeds to rule out malabsorption and GERD. And no history of crying while passing urine, frothy urine or dribbling of urine or cola-colored urine. No history of successive cycle, breathing difficulty, recurrent respiratory tract infection, bluish discoloration of skin. No history of yellowish discoloration of eyes, skin, or vomiting or any abdominal distension to rule out hepatic causes, and no history of loss of consciousness or convulsion, with no history of recurrent fever, respiratory infection, or diarrhea, or oral ulcers and ER discharge suggestive of immunodeficiency disorders.
Okay, we can say nothing suggestive of other systemic diseases. Why did you bring all these conditions?
Ma'am,
Because
since child is having edema, to rule out other causes of edema.
Edema as well as growth faltering. Nowadays, the term failure to thrive is WHO has nearly dropped it. We don't accept failures. That is why. Okay, failure to thrive is not there. It is growth faltering. Okay,
Yes.
continue.
So coming to
So
past
we cannot
history.
rule out by history suggestive of renal disease. Like that is the better word to use.
Okay.
Okay, continue.
No history of recurrent or persistent diarrhea in the past, or no history of previous hospitalization for the child.
Okay.
And coming to family history, so nuclear family, a second order child of third degree consanguineous married couple with history of sibling death at the age of 2 years, and child had a similar illness, multiple episodes of diarrhea and prolonged fever. The illness was continued for 2 months, and child was taking less feeds, was treated with Ayush medications at home, and they didn't seek any medical attention, and a child succumbed during the illness, with no history of chronic cough or tuberculosis or any other chronic illness in the family. So this is a family.
Do you think this siblings disease has something to do with this child's disease also?
Probably can be there. There can be a immunodeficiency, maybe congenital or acquired.
Okay. So you are thinking of some other condition also, a genetic condition or an acquired condition. Which acquired conditions can come? Genetic, we know. What is the new term for that immunodeficiencies? What is the new term?
Nutritionally acquired immunodeficiency.
No. I am asking about genetic causes. It is now called, not called inborn error. It is called inborn errors of immunity. So,
immunity.
So you are thinking of that plus acquired. Which acquired causes you are thinking of? Coming again and again.
Nutritionally acquired immunodeficiency, or can be even
so
HIV.
Usually, or HIV/AIDS. Okay, that can come in subsequent babies, and it can lead to mortality also. But I am happy that you brought in nutritionally acquired immunodeficiency syndrome. That is by far the commonest, but most of the students will answer only the inborn errors of immunity and HIV/AIDS. Okay. We'll come to more details in the discussion. Okay. So it's very sad that they lost the first baby also. Immunodeficiency syndromes are more common in males or females?
In males, ma'am.
Males, but these are both females.
Yes.
Okay. So they both of them presented with diarrhea. So which immunodeficiency are you postulating? You said, I think, already. What is the local protection for our respiratory tract
IgA
and
IgA deficiency
and intestinal tract? We inhale and ingest bacteria, viruses. The local protector is IgA. And for breastfed babies, it is secretory IgA. That is why we say breast milk is a lifesaver to millions of children. Okay. So IgA deficiency, you are postulating. Okay. Go ahead.
Coming to antenatal history, the mother was conceived at the age of 26 years. A birth spacing between first and second pregnancy was 11 months. She was a book case, and weight gain during pregnancy was 10 kg.
Birth spacing is the term, and it is not between two pregnancies. It is between two births. Okay. That you have highlighted. So some don't have an idea that it is between two deliveries. Only 11 months. So what can be the implication of that?
First baby might not have been fully breastfed.
So both babies are at risk, and the mother is also at risk. She has not recovered her health, her iron stores, calcium stores, and looking after two very small babies also, very difficult, no? So that is that will add on to the morbidity and mortality of both the babies. And Cecily Williams described that malnutrition is the disease of the first child, isn't it?
Yes, ma'am.
When the second child is born, usually a toddler, we mean. Here it is an infant. Okay. Continue.
Okay, ma'am. She was a book case and which weight gain during pregnancy was 10 kg, which was low for her pre-pregnancy BMI. And all the 3 trimesters were uneventful and scans were said to be normal.
Okay. So what is this pre-pregnancy BMI and weight gain? Enlighten
Ma'am,
me.
for according to BMI, the weight gain differs.
Hmm.
For a mother with BMI less than 18.5, will
Her
have to
BMI
gain.
was less than 18.5, isn't it?
Yes, ma'am. She was 17.
So she should have gained 12.5 to 18 kg. And for a normal mother,
Should have been 11.6 to 16 kg, ma'am.
16. And obese mother,
And for obese mother, for a overweight mother, it should be between 7 to 11.5, and obese 5 to 9 kg
okay,
of weight.
this is an important concept that we have to instill to our students also. Usually they are taught that 10 to 12 kg is normal. The obese mother should gain less weight and the underweight mother should gain more weight. And for pre-pregnancy BMI, we need the pre-pregnancy weight. But when it is not there, is there any shortcut that we can apply? We can...
The first recorded weight can be...
Yeah, first trimester weight, because there is no weight gain in first trimester. So first recorded weight can also be taken as a surrogate of the pre-pregnancy weight. And her height won't change, no? So that is it. Okay, that's a shortcut. Okay, continue.
Coming to birth history, a full-term child, a full-term baby of birth weight 2.8 kg was delivered by normal vaginal delivery, and she was said to have cried immediately after birth with no history of an ICU admission, and she was discharged on day 2 of life on exclusive direct breastfeeding. Mother continued supplements for 3 months postpartum.
What is the recommendation of according to the government or
up to 180 days?
She should be taking 180 days. Okay. You have said something. Go back to your previous slide. You said something about previous slide. Birth length and head circumference node. No. Why do you want all
that? Whether the baby is losing weight, to check whether she has risk from womb.
Weight, the growth during the first year of life is a continuum of the intrauterine life. So we want that. Birth centile of weight, length and head circumference are very important to interpret. Which centile the baby was born and is the baby maintaining that centile. And for intrauterine, what centile is good and what centile is growth restriction? Less than?
Within one. Less than 1.
No. Intrauterine growth less than? Anybody else? 10th percentile. Actually, it is the 10th percentile, whereas in postnatal growth, we are taking up to 3rd percentile. So you understand? That is why now they say that the term 2.5 kg for all low birth weight baby is absurd. We should say whether what was the centile at birth and is the baby maintaining that at least or having catch-up growth. So 2.5 kg baby is a 3rd percentile. So in utero, suppose the baby was in utero yesterday, I'll say that baby is growth restricted. Today the baby is born and I take the baby to WHO chart and I say that the baby is normal. So now they say that the 2.5 cutoff is also not very applicable. we have to go by SGA, AGA, etc. and aim for whatever birth centile they were born. Okay, continue.
So
But
coming to dietary history,
most of the birth records have only weight. I think we should always record when we are evaluating for short stature also. We want to know what was the growth potential in utero. Head circumference, some people write. Length, many don't write. Okay. We should make it a point that all the three are mentioned in the birth record. Continue.
so coming to dietary history, child was exclusively breastfed till 7 months of age, 7 to 8 times per day and 2 to 3 times at night. Was not ensuring emptying with no history of bottle feeding or formula milk.
What is the
Complementary
importance of
feeding.
emptying? Ensuring emptying. What is the importance?
Ma'am, formula contains
That baby gets
for-
hind milk. Okay. Not only fore
Yes.
milk. Many mothers don't ensure hind milk and they shift from one breast to the other. So the baby may not be getting hind milk, which imparts growth, especially brain growth, because it is high in fat. Okay. And the second is
Okay.
milk production is dependent on emptying. So if they don't empty, there is something called feedback inhibitor of lactation, which will locally the autocrine control in lactation. There will be less milk production. Suppose there is engorgement on one side, milk production will come down on that side. But on the other side, all the reflexes are working and there will be good milk supply. Okay.
So complementary feeding was started late at 7 months, and breastfeeding
So
was
what is
continued.
ideal? What is ideal? Completion
Start
of
at 6 months.
6
ma'am.
months. Okay, continue.
And breastfeeding was continued, and ragi once daily was given along with breast milk. So only 2 out of 8 food groups was given with no other food items during that period. Later, rice, wheat, and dal were added. So currently, child's food intake is reduced with a breastfeeding of 3 to 4 times during day and 1 to 2 times at night, along with complementary feeding. So coming to,
How do you assess? How do you assess the sufficiency of complementary feeding? What are the indicators?
minimum meal frequency.
Go to that.
And a minimum dietary diversity should be there. So
Yeah.
it
At
should
least
include
5 out of
at least
the
5
8
out
food
of
groups.
8 food groups.
Okay. So baby was getting only 3. 3.
Yes, ma'am.
Okay.
3 with breastfeeding.
And minimum dietary diversity, you said. What about minimum meal frequency?
She had a minimum. She had a frequency of 5 meals per.
Next slide.
So minimum meal frequency is the frequency
So after 6 to 8 months, breastfed babies should have at least 3, and non-breastfed babies should have 4. And after 1 year, it is 5 times 5 colors, 5 food groups. Okay. So those who meet minimum meal frequency and minimum dietary diversity only will be considered as minimum acceptable diet. What percentage of Indian babies get minimum acceptable diet as per NFHS 6?
6.
NFHS 5, it was 11%. Now it is 15%. Okay. Go to the diet. Show the diet. What you have calculated. Go. Yes.
So dietary history, the pre-illness, according to 24-hour recall method.
3 or 4, 3 food groups and breastfeeding is there. Okay. So total energy is, it is mainly cereal, rice, wheat, ragi. All are cereal or millet. That is energy food. Then 1
banana.
Only little bit of dal is given plus breast milk. So protein is very, very less. Micronutrients are also very less. Okay. So total energy is
There's a deficit of 62%
mhm.
kilo energy and 57% of proteins.
So how much is required for basal metabolic rate of the
Uh,
RDA? At least
20,
50%. No, 50%.
50%.
So baby is having a deficit of 62%. So it is actually, it goes to low BMI, no activity, no growth, like that. Huh?
Okay.
Okay, okay. What about micronutrients? Plus breast milk. So don't cook up any calories for breastfeeding and add 6 gram protein, 12 gram protein, etc. You write whatever you got plus breastfeeding. And in the interpretation, we can say that the gap is not bridged by breastfeeding, so the diet has to improve. In some other child, the diet seems to be very less, but breast milk is bridging up the gap, maybe a younger child. So on examination, the nutritional status is normal. So breast milk is bridging the gap. Here you can say that breast milk is not bridging the gap. Okay. And sometimes when we add up, protein may be slightly more. 12 gram is required, but it is 15 gram. Don't highlight telling that there is 2 gram excess protein. That is mostly, all the recommendations are based on complete protein for this age, milk protein or egg protein, reference protein. But what the baby is getting is from the vegetarian sources, which is incomplete protein. So you must say that it is made up as per the history. Protein intake is sufficient by numbers, but it is mostly incomplete protein. And when there is so much of energy gap, it will be wasted for energy. And 1 gram of protein will give only 4 calories. Even if you tell there is 10 gram protein excess, it is not going to be utilized for any bodybuilding or repair or enzyme production, etc. It will be wasted for energy because basal metabolic rate has to be maintained. No, okay. Continue.
Okay, ma'am. So with nutritional supplements, vitamin D was given till 3 months of age.
What
Vitamin
is the
A, first dose
recommendation?
of vitamin
What is the recommendation?
till 2 years, ma'am.
Yeah. Usually we say at least till anterior frontal closes. Okay, we can give 1.5 to 2 years. Okay, then
First dose of vitamin A was given during vaccination at 9th month, and zinc during diarrhea was not started yet. And iron folic acid child was not on iron folic acid supplements.
mother also stopped IFA. No, as per Anemia
Yes,
Mukt Bharat, mother should be on IFA for 180 days, 6 months, followed by weekly because she is WRA. What is WRA? WRA is women in the reproductive age group. They are beneficiaries for weekly iron. And lactation, 180 days, they should be on IFA. And then the baby should be on bi-weekly iron. It is, the recommendation is that whoever is not on this Anemia Mukt Bharat recommendation, mother not on iron, baby not on iron, at 9 months, we should screen for hemoglobin. And because iron is so much important for brain growth, cognition, myoglobin, hemoglobin, muscle power, etc. Okay, next, continue.
So, immunization history, child was immunized as per NIS schedule, and other vaccines recommended by IEP were not taken. Last vaccine was at 9th month, along with vitamin A, and BCG scar was present.
BCG scar is present means, what does it mean to you? BCG scar is present means, what does it mean to you? One is BCG was given.
Cells.
It's a proof of that BCG is given.
Cell-mediated immunity.
Yeah, very good. Cell-mediated immunity is good. Okay, because we were postulating about some immunodeficiency in this child. And in HIV, AIDS and all, T cell is gone. So more of fungus infection will be there, oral thrush. But at that age, it won't affect, no, newborn period, 1 to 2 months, even if HIV baby, may not have all the immunosuppression. But this practically says that T cell immunity was good in this baby. So we can consider B cell. As you said IgA, no? IgA is B cell mediated. Okay.
Yes.
Okay. Next. Next.
Development history.
Hmm.
In motor, gross motor had a moderate delay with development quotient of 80%.
What is severe
In
delay?
social,
Less than
70,
70%. Okay.
75.
70. And fine motor is?
Fine motor is normal, ma'am. Social,
Nine-
language, and cognitive are normal. 92%.
Language also good. So what is global developmental delay?
More than two
or
or
more domains are affected. Which are the domains? Which are the 4 domains?
motor, social and adaptive, language, and cognitive.
Yeah. So in Denver and all, it is given all the charts. It is given fine motor, gross motor. So students say fine motor, gross motor, social, language. But cognitive milestones are there, and vision and hearing are good. The good that you did it. Why this baby is having gross motor delay? Only.
Can be due to wasting, ma'am.
Yeah, muscle strength is less and
Less potassium levels.
yeah.
Hypokalemia.
Okay. Hypotonia, muscle weakness, muscle wasting, etc. Okay. So how do you assess cognition? What are the milestones? Can you show
Slide
us?
for that, ma'am.
Yeah.
So the child attain attention by 3 months of age and plays with own hands and feet by 6 months. And a child will be interested in sounds of objects by 9 months, and peekaboo by 12 months.
So there is a approved milestone chart for cognition also, which is usually forgotten in our teaching as well as in our presentations. That is why it is brought here. Okay, continue. Good. Continue.
So in socioeconomic status, they were living in a rented Pakka house and using borewell water for drinking and household activities. Father studied till 8th standard and works in factory. And a monthly income was 9,000 per month, and they belongs to upper lower class of class 4 according to modified Kuppuswamy's classification 2026.
Okay. How is Kuppuswamy scale modified every year? Almost every year.
By family income, ma'am.
Yeah. All others remain same, no? The education, occupation remains same, but they, as per the inflation rate, they revise it. So this family belong to 10 score, you said. Huh? How?
Yes, ma'am.
Okay. Income.
Income scores will be 2 and craft and related trade workers 4 and a middle school 4, ma'am. So 10.
Okay. Continue. So when you say Kuppuswamy scale, you will have to say the year also. Which year? Now 2026 is available. Okay, next.
So summarizing the history, 15-month-old female child, a second order child of the 3rd degree consanguineous marriage, presented with poor weight gain for 6 months and bilateral hand and feet edema for 15 days and loose stools with fever for 3 days. She had a significant family history, a sibling death due to diarrheal illness without medical care at 2 years of age. The birth spacing was only 11 months. Antenatal, natal, and postnatal history were uneventful. Full-term normal vaginal delivery with a normal birth weight and no NICU stay and child was discharged on direct breastfeeding. She was having an inadequate complementary feeding, only 4 to 8 food groups was given, not meeting minimum dietary diversity, hence not a minimum acceptable diet, and not on any micronutrient supplementation. And our child was immunized till 9 months according to national immunization schedule, and gross motor delay was there with a development quotient of 80%, belongs to upper lower class of modified Cooper service scale.
Yeah. We can go to examination now.
Ma'am, just for a few minutes, Dr. Ketana, shall we go to the first slide?
Yes,
That
sir.
is complaints. No, I want to bring more from Professor Elizabeth. That's why the purpose of asking some questions.
Yeah, we have
Right.
more coming.
last-
Yeah.
Microsoft is- Okay, next slide.
Next slide.
Next slide.
Yes, sir.
So you have to tell us what happened to this child also. Usually, no hospital course we may be telling.
So whenever you are talking about fluid collection, that is edema, you may tell which part of the body is first affected. Okay, right. It has some
Okay.
significance. Okay, right.
Thanks, sir. Yeah.
Okay, next slide. So loose stools, you have to mention not only back the previous slide.
Previous slide.
Yes,
You
sir.
have jumped one slide. Loose stools. So there is no mucus or blood. What is it suggestive of? Tenesmus, presence of blood and mucus in the stools is suggestive of?
Dysentery.
Yes. Involvement of the colitis and tenesmus is suggestive of rectal involvement. And what is irritability and crying? What does it indicate?
So child is having some dehydration.
Yes, you are right. There are two things which contribute to irritability. One thing is, you may be saying, it is diarrheal dehydration. What else can cause lethargy, irritability, and peevishness? Doesn't want to get disturbed. What do you think of?
Especially in this child, and
this toddler.
Hypokalemia.
No, this toddler is having two things. One thing is undernutrition broadly. Second is diarrheal dehydration. Right.
Yes,
So
sir.
the peevishness, irritability, lethargy, not inclined to get disturbed, not interested in surroundings. These things are suggestive of, especially in the presence of associated edema. They have some significance. What is it?
what is that? What state of malnutrition?
No, somebody else also. No, it's not Dr. Ketana alone. The questions are all for all postgraduates.
What type of malnutrition will have Mendel changes?
For sure, Karan.
Right. Okay. Go to the next one. So you see what is the contribution of the primary disease, right?
Yeah.
Rather than the one which has started just 3 days back. Okay.
So
Because of maybe diarrhea and also because of the undernutrition with edema. Okay. Next.
Okay, sir.
Both are contributory.
Dr. Kirtana, there is a question for you. Any triggers at 9 months, say exanthem like measles or anything?
Yes. Exactly, ma'am. That's what I'm going to ask in the past history. Right. That's
no, ma'am, nothing.
No significant illness or hospitalizations, she said. Okay.
Right.
You can specifically say.
Asking about exanthematous diseases, Dr. Ketana. It has a lot of significance.
Okay, sir.
Anybody, not Dr. Ketana, any postgraduate. See, measles is one condition which causes significant immunodeficiency, especially decrease in the cell immunity.
Go to past illness.
Starting point either for any tuberculosis focus to set in, or flaring up of the existing tuberculosis, or worsening the undernutrition, or it may be the starting point for the child going into undernutrition. And it is the point where the toddler is likely to have micronutrient deficiency. So history of exanthematous disease, especially measles, is very significant. Okay, previous slides. Just previous slides. Dr. Ketana, previous slides, please. Try
Yes, sir.
to decrease the number of negative history unless they are very much relevant. You ask for history of worms due to what for?
In this setting, due to poverty, can be helminthiasis.
No, it may be one of the causes that triggers undernutrition. Okay, asking is one thing, and justifying is also important whenever it is negative history. And when there is no specific history of large bulky stools, small absorption, rejection of feeds, I think you may do away with that with due respect to your mentor, because many examiners are not kind to too much of negative history, right? We have to keep them in our mind. So instead of saying all those things, you may say urine is normal color. That's it. Simple. Instead of saying negative, you say positive connotation. No, both are same. So there was no history of breathlessness. That's why the edema cannot occur in the absence of breathlessness, leave alone exertional breathlessness. The child was never breathless. So we don't think decompensation, cardiac decompensation leading to edema also of upper lips. Suppose the history of dyspnea, you may ask, just cutting down the negative history. Many examiners are not like, simply say there is no breathlessness. So when there is no breathlessness, there is no doubt why there should be pedal edema. And I think regarding yellow discoloration, I didn't find any reason for it. And why did you ask for loss of consciousness and convulsion? At the maximum, you may ask for any mental changes. That's it.
Okay.
Because there's nothing to think the baby may have convulsions, isn't it? Just to cut down the negative history. This is very important. No history of recurrent fever, either respiratory or gastrointestinal, right? And you may ask about oral thrush, more than the oral ulcers, right? And immunodeficiency with others. Next, fast. We'll go fast. Next slide, please. Next slide. That's it, is it? Next. So history of exanthematous fever is very important, right?
Yes.
Next, we'll go. See, what could be the cause for the death in the first baby?
Probably malnutrition with
In this setting,
dehydration.
not fortunate,
Dehydration.
or we may not consider. Of course, we have to consider and exclude any primary immunodeficiencies or inborn errors of immunity. Because say prima facie case, the baby, the scenario in the house which led to significant undernutrition in the second born, it is most likely to cause the firstborn for the reason the first baby did not have the breast milk, not blessed to have the breast milk. Even for 2 months it appears, or 3 months. Okay. So before going to immunodeficiency, you may consider probably most likely it may be nutritional cause. Next. Quickly. Right. Next, please. Okay. Nothing specific in the antenatal history. Next. Right. Next. This is also nothing specific. Next. So nutrition history, you have done it in an elaborate way, nice, and calculation of next. Calories and proteins is very essential. See, we do it on all the children, but more important to elaborate about a nutrition history and calculation of deficit in a child with undernutrition. She has rightly done. Next, both 2 slides. Proceed. Quickly.
Continue.
Next slides. I'm not hurrying you to save time. To Dr. Elizabeth. Right.
Yeah.
Right. Next.
So it's very important to tell about nutritional this micronutrient supplementation. National programs are there, but this child has not been a beneficiary of any of these.
Right. See, and one point
That
to
should be
notice-
said in the dietary history itself. Otherwise, we
Right,
may
right.
not get a chance to say that.
Yes, yes. See, and we should not be under the belief that overweight children may not have micronutrient deficiencies. It can still occur. It is because of the empty calories that make the child overweight or obese, and which may not be providing the micronutrients. Next.
That's
So
why the
even
term
overweight-
protein energy malnutrition also has been dropped. And now it
Yes.
is PEM is taken over by the pediatric emergency medicine.
Right. Right.
Okay.
Why PM was withdrawn? Somebody can tell why that wording is taken out. Because it is oversimplification. It simply says there is deficit of proteins and calories, nothing else. But it is a more complex than what the name indicates. And Dr. Ketana and others, see, the cognition is affected in a child with severe undernutrition, not just because of both development as well as cognition. The children with severe undernutrition are likely to have the retardation of the development DQ by 6 to 13%. 6 to 13%. Generally, we think that undernutrition causes retardation of growth. No, it affects the development also. The DQ may be affected, total DQ, put together all domains. It may be affected up from 6 to 13. And cognition is the one thing, as Madam rightly told, that is to be assessed more so in child with undernutrition. And what are the micronutrient deficiencies that are likely to cause, important micronutrient deficiencies that cause cognitive deficit. In any child, more so in child with undernutrition. Cognitive deficit. It may be iron, maybe iodine. Say they cause significant cognitive deficiency. Right. Next.
Continue.
Next. Right. You have you brought out these things very nicely, socioeconomic, and next. So this socioeconomic status, illiteracy, ignorance, they are likely to affect the child's growth and nutritional intake. Now, may I request our Dr. Balasubramanian to give his comments on history.
I have very little to add. Brilliantly discussed by Professor Elizabeth and you. But I have a few questions to the student. You said that the problem started at 9 months. From your history, you had actually mentioned that the problem started at 9 months. How sure are you it started at 9 months? How did you come to that conclusion? That's number one. Second, it's a usual mistake made by PGs. You concentrated on development, but I never heard anything from you on the head size of the baby, on the teeth of the baby, on the other milestones, including auditory and visual. And I'm not sure when the problem started. Though you came to a conclusion the problem started at 9 months, you didn't substantiate. You didn't mention the weight at 9 months, the weight at 6 months. Then only the weight gain had been good in the first 9 months. Then the starting point for this problem might be at 9 months. If even before the weight gain had been lagging, the head had been small, maybe had not been growing well even before that, it takes you to different etiology. That's my comment number 2. Third comment is, in addition to immunodeficiency, which you said because there is consanguineous marriage and a sibling death, you should also think of a disorder of bowel causing malabsorption, killing the previous child. You assume the previous child died because of SAM due to diarrhea. And the diarrhea need not be infectious, could have been some congenital diarrhea manifesting at the second year of life. And the same
Yes.
disease might be happening. Same disease might be happening in this baby. It need not be always immunodeficiency. It can be congenital disorder of the small bowel, which can manifest late. IPEX syndrome, notorious. In which case, your history of global developmental delay will very nicely fit in, because it can be associated with hypothyroidism, in addition to malabsorption, chronic diarrhea, etc. And of course, the other thing that I would have liked to hear is not only the diet, what the child is presently getting, but also the diet child had been getting in the past. You should give a comment saying that even before the onset of the diarrheal illness, the infant was not getting enough food. And last is, after the diarrhea started, what has been the diet that the mother had been giving? That also is important. It may have relevance to diagnosis as well as the severity of the illness, right? And finally, Madam very nicely mentioned about the breastfeeding not being very significant in this age. Agree. But having said that, the rule of thumb is the maximum amount of milk, if a mother is nicely breastfeeding, the first 6 months it may be around 600 ml. 6 months to 1 year, it can be around 400 ml. And above 1 year, no mother will secrete more than 200 ml. Maximum is 200 ml. That's why what Dr. Elizabeth said, it is not nutritionally significant, that need not be counted for calories, is very nice. I appreciate that. And finally,
Even small
any
babies
faltering in growth.
Even small babies,
when there is
they-
faltering, yeah,
the students will add
please, ma'am.
600 calories, 800 calories, etc. for breast milk. But we don't know. It varies from mother to mother, mother-infant diet. We can assess the nutritional
Correct.
status and say plus breast milk
Correct.
if you type
Correct.
that.
Yeah. And yeah, agreed. And finally, this infant, this toddler is faltering in growth. Once there is faltering in growth, I mean, I have a very unconventional way to approach. Dr. Elizabeth would agree. These days, primary nutritional problems causing the so-called faltering in growth, or SAM, is becoming much less common than organic disease. I'm sure Professor Elizabeth would agree.
Yes,
We don't
exactly.
see the Cocktaker type like we used to see in the past. Most of the faltering in growth, or most of the so-called SAM that we see, they are all secondary to underlying disease. And for the underlying disease, I find this approach being extremely useful. The approach is, when you have faltering in growth or failure to thrive, whatever you call it, it comes into only one of the four groups. 1, too little in. 2, too much out. 3, too much is required. 4, too little is utilized. I'm going to ask the PG, which group do you think is resulting in failure to thrive or faltering in growth in this child? Where is the problem? Hello, Dr. Kirtana?
Sir.
Yeah. Which group? I'm again repeating it. Too little is in, too much is out, too much is required, and too little is utilized. Where is the problem in this child?
Too little is in.
In fact, if I were to answer this question, I would say too little is in. There is also too much is out. The child is losing in the bowel. Child is also taking very little. In fact, what is important for faltering in growth, what we nowadays see is dual etiology. It's not always only one problem. These are my comments. Excellent discussion by Professor Elizabeth. Thank you.
Dr. Kirtana, why did you boil down to 9th month? What happened? What was this history? 9th month?
At 9 months, during routine vaccination visit, she was said to, mother was said to have a child with less weight, ma'am.
The health workers told that
Then
the
she
yes,
started
but
noticing.
she didn't remember any weight prior, no?
No, ma'am.
Most of the
Then she started
immunization
noticing.
clinics, they don't take the weight. They say it is too much burden for them. It is too overcrowded, like that. It would have been nice to have all the weights recorded, but it was not available. Okay.
Right. Proceed, Dr. Ketan.
Yes, sir. General physical examination. Child is conscious, recognizing mother, not interested
Change
in
your slide.
surroundings.
Ah.
This one change. Irritable and anxious, and child was having edema of hands and feet, and pallor was noted. So this is a picture of her.
Even the examiner's hand is pale. I think the lighting something is
Very
wrong.
much correct. Probably the problem of
Lighting
reflection of light.
is not
Right.
something went wrong with the lighting, I
Okay,
believe.
okay, man. Right, you are.
Okay. So
I'm not able to see the slides. It's very smudged.
Yeah, I think you can make it full screen, Dr. Ketana, if you can.
try
Dr.
to
Ketana,
make it full screen.
make it full screen.
Yes, ma'am.
That.
No,
Yes,
no.
yes. Correct. You are doing correctly. If it doesn't work, you go to slideshow and go from current slide. Either way is okay. If this is not working.
Top, there is a slideshow.
See, top in the slideshow at 11 o'clock, 12 o'clock position. Click it. Then
Yes, ma'am.
go for current slide.
So I've given, sir.
It's
Yeah,
still
yeah.
showing the summary slide only.
No, you have not gone to slideshow, Dr. Ketana. I'm seeing
Sir,
you have clicked on the
Usually in
bottom.
Zoom, this mistake won't have come, but usually in other
Yes,
teams and all, it comes.
that's good.
No, it's not coming. It's not coming.
Okay,
Okay.
proceed. You try to describe what you have observed quickly, fast, because we are
Okay,
running
sir.
short
This
of.
child is irritable.
Ah.
It's not interested in surroundings. She has edema with the skin is shiny.
Yes.
The legs show dermatosis.
No, first of all, say edematous. Then talk about the skin. See, what is the edema of the skin? Registrar. You said
Sir?
there is edema of the skin.
Yes,
Apart
sir.
from edema of the limb. Yes, observation is correct. When it is shiny, it tells there is collection of fluid in the skin and subcutaneous tissue. And in turn, it suggests a hypoalbumemic condition. Okay. This is the feature in same with edema and Kwashiorkor and nephrotic syndrome. All are hypoalbumemic conditions. So your observation of shiny skin is suggestive of collection of fluid in the skin, subcutaneous tissue. Yes. See, the edema of the upper lips is more in favor of undernutrition. Without there being generalized edema, mainly lower limbs and then upper limbs, again it suggests more, it points towards the nutritional deficiency. Okay, parallel, you say we take it. Next.
So the vitals.
Ma'am, Dr. Ketana.
Yeah.
This is one baby which requires thorough, complete general examination. See, the most of the findings you are going to tell us is only in the general examination. You start from the head and we are telling in the next slide.
It's coming,
This
sir.
was done because the baby has to be triaged. So when the baby had diarrhea, that is why vitals are put. And then she's coming to health to foot in detail. So for triaging, this is important. Vitals.
Okay. Now, next slide is there. Okay, fine.
So shall I proceed?
Yeah, we can see.
Yes, proceed.
So,
Proceed.
No, we could read it. You may proceed. If there is anything specific, you tell, otherwise. we'll go
Temperature
on.
was febrile,
Hmm.
rhythm, and
Time
normal
of
volume.
examination, the child was febrile, but they came with history of fever.
Yes, sir. Yes, ma'am.
Hmm.
With a respiratory rate of 28 per minute, and abdominal and thoracic type with no fast breathing. And she had a BP of 80/56 mmHg in right upper limb in supine position. And SpO2 was 98% in Romare, and CFT was less than 2 seconds, GRBS of 78%.
So these 7 vitals are important when you triage the child into pink. Otherwise, you need not do all this GRBS, SpO2, etc. Ambulatory cases you may not do. Okay.
Okay.
Next.
So coming to head and foot examination, there was pallor was present, no icterus, sinus, clubbing or lymphadenopathy. And assessment of dehydration, the child was irritable and was drinking eagerly with skin pinch going back slowly, and child had reduced urine output. In her head, there was frontal bossing with anterior frontal layer was open and at level, and hair was lustrous, sparse, and thin and brown in color with no areas of alopecia. And in face, she had mild puffiness, and eyes pallor was present, and conjunctival cirrhosis with sunken eyes was present. Ears shows no discharge, and oral cavity was normal. Lips and tongues with no cheilitis, stomatitis, glossitis, oral ulcers, or thrush or any dental caries was there. No lymphadenopathy was present, and chest was normal with no Harrison circus or rachitic rosary. Abdomen was normal. Extremities showed bilateral pitting edema in the dorsum of hands till wrist, and in dorsum of feet till ankle. And there was shiny skin over the edematous region with no knuckle hyperpigmentation. And nails, pallor was present and no spooning of nails seen. Spine was normal, genitalia normal, and perianal excoriation was present. In skin, there was dry skin and dermatosis in flexures, and skeletal system was normal.
How do you elicit edema in a cardiac case? And how is this different?
In cardiac case, it is dependent edema. So we'll check on the behind the medial malleolus, and in nutritional edema on the dorsum of foot.
Ankle edema is, yes. And here it is on the dorsum, which is not, ankle is more dependent than the dorsum of the feet. And this is finger pressure for a few seconds. Okay.
Yes, ma'am.
Okay. Continue.
So she had a hyper and hyperpigmented areas, which is called as flaky paint that may be present with erythema. And crazy pavement is when there is infection and it gets ulcerated.
This is added just for teaching purpose.
This is not having it. Okay.
Our baby doesn't have crazy pain.
Having only the flaky pain, which is typical. You can see it is a dry lesion, whereas nowadays we hardly see this crazy payment. Whatever we see, we call it nutritional dermatosis, because it is not the as per textbook descriptions we see. Okay. This is a teaching slide.
This is not our child's photograph.
We will go back. Dr. Ketana, shall we go back?
Yes,
See, general examination is very important in this toddler. That's why just we'll go back to general examination.
Yes, sir.
General examination description. So you have to tell about the mental changes, edema of hands, feet, and edema of the face is also there, right?
Yes, sir.
Edema of the face is there, and pallor is noted. See, we conventionally we have only 4 systems for broadly for a systemic examination. So there is no hematologic system included. So you are, whenever there is pallor, you are expected to further analyze the cause or the findings which are supportive of particular etiology. So whenever there is pallor is noted, immediately think whether it is causes of pallor. Of course, not in this child, in any child, absence of icterus, hemolytic are out. In this being a child, classically undernourished child, it is nutritional. In nutrition, again, you have to differentiate whether it is iron deficiency or macrocytic anemia.
Solid.
So you have to look for the findings suggestive of the underlying etiological factor in the general examination itself, following the mentioning of pallor. Okay, you probably got it. Next. Next.
Show the head to foot.
So vitals.
Next.
Yeah, that is discussed. Head to foot.
Right. Next. Right. See,
Yes, sir.
the pallor present, no icterus, cyanosis, clotting, lipidopathy. No, this is correct. Right. See, whenever you are assessing for the dehydration in a toddler or a child with edematous undernutrition, we will not assess the skin turgor.
Okay, sir.
It is not reliable. The reason is the so-called tenting sign will not be obviously present for the fact the skin and subcutaneous tissue are edematous.
Edematous.
So we better not rely on the test that is assessing the
Yeah.
skin turgor. Okay. So
Yes, sir.
urine output, yes. Especially the urine output would have been a little less prior to diarrhea, and it is much more significant after that. Right. Irritability for both the conditions, and Drix eagerly says that it is still some dehydration. The reason for frontal passing is
Can we do vitamin D deficiency, sir?
and Farnella, you expect it to close by this time, right? It has not. It got delayed. Again, maybe vitamin D deficiency.
D
What
deficiency.
would be the color in case of undernourishment, severe undernourishment, color of the hair? It may
Black
be,
sign.
no, it will not be black.
Black.
It may be pale or red, right?
Okay, sir.
Reddening of hair.
That is
Hy-
also
And
rhabdoid.
hypochromotrichia.
Hypochromotrichia, right? What is the cause for sunken eyes in this child if it were to be there? Again, both the conditions cause. See, assessing the dehydration and in a child with edematous undernutrition is a little tricky, right? There can be sunken eyes in both undernutrition as well as some dehydration or severe dehydration. In undernutrition, what is the cause for sunken eyes?
Since other tissues.
Loss of, see, the skin and subcutaneous tissue, there is fat loss and then muscle loss. Retroorbital fat loss results in sunken
Yes.
eyes. In dehydration also it can occur, right? And the conjunctival and corneal cirrhosis also you mentioned. What for? Again, this is also both can contribute to cirrhosis. Why in undernutrition? Why should there be cirrhosis? There are again, see, for any symptom or sign, try to ascertain how many etiological factor may contribute for the particular symptom or sign. What could be the cause for cirrhosis in a child with undernutrition?
Can be vitamin A deficiency, sir.
One thing is very good. Vitamin A deficiency shall come foremost to our mind because that is the earliest sign of cirrhosis. The earlier sign. You have to be very cautious in catching up the vitamin A deficiency at its earliest. The second cause is there will be decrease in the lacrimal and salivary gland secretions. Again, this may occur. It's not the decrease in secretion. In dehydration, the eyes can be dry and oral cavity also can be dry. In undernutrition, it is because of dehydration, diarrheal dehydration. Here it is because of the decrease in the secretion of the salivary and lacrimal glands. Got it? So then how to delineate in a child with undernutrition what is the extent of dehydration? See, skin turgor is not useful, cirrhosis is not useful, oral mucous membrane assessment is not useful. Then on what we have to rely upon? Somebody give some rest to Dr. Kirtana. Urine output, Dr. AP, you are right. What else?
And
Seeker relief.
thirst.
No, let others speak. You take some rest.
So along urine output is one.
What
The
else?
other one is what else?
No, others will tell. Dr. Kirtana, complete, suppose they are present.
She has written it there.
Yes.
Drink seagulls.
Thirst.
No, gum bleeds
Yes.
are due to, if it is present, what I'm asking. So you try to learn all the features, cause for colitis, cause for angular stomatitis, right? Spongy
sir.
bleeding gums, all these things you may be asked in the examination. Thus she mentioned to know about some immunodeficiency. Next slide. See, it's mostly general examination. This child may be having some abnormalities. Next, that's why you would like to have some time. And just normal. See, don't say normal. You would have been wasting of the chest muscles, right? You
Yes,
should
sir.
have been very clearly. See, that's not normal, of course. You may say chest inside is normal. And why rachitic rosary may not be prominent despite there being vitamin D deficiency? Why there may not be
In this
lower
child.
changes of vitamin D deficiency in a child with severe undernutrition, despite there will be, it is significantly present. Somebody tell me.
What is the reason?
What is
We
the
may
reason?
not
It
see
may
all the
manifest.
florid features of rickets.
Because can endochondral maturation may not.
No.
See, probably
Dr.
Professor.
Mala has answered. Actively growing bones. It's a
Yes,
disease of
Dr.
the
Bala is
growing
correct.
bones. Okay.
See, those things are found only when the bone growth is active. When there is no active bone growth, the deficiency features may not be clear. So, absence of these things doesn't rule out the child be vitamin D deficient. Abdomen may be distended. What could be the causes? Quickly. Anybody?
Ascites due to
One thing is it is
epididymitis
good. Pardon?
and then hepatomegaly,
Good. Because of the fat collection.
liver.
Good. Then
When they cry, what happens? What will get in? Aerophagy. Okay.
right. In the children, there is bacterial overgrowth in the intestines. That also will cause abdominal distension in child with undernutrition. Next comes hypotonia of the abdominal muscles. That weakness, abdominal muscle weakness. That also can cause abdominal wall distension. Then how to know whether the abdominal distension is because of hypotonia of the abdominal muscles or ascites? Without touching the child.
What do you look at? Something in the middle of the abdomen.
Umbilicus.
This is the period of lumbar lordosis physiologically and some abdominal distension. And I would like you to differentiate between the abdominal distension because of physiological cause or because of hypotonia of the muscles, abdominal muscles. See, simply make the child lie down. If it is because of the hypotonia of the abdominal muscles or trunk muscles, the lordosis disappears. Okay? And physiological also. Am I clear? Right.
Yes, sir.
Okay, normal perineal expression. Okay. See, perineal excoriation, you would like to put the money on?
Ectodermatite, zinc deficiency.
You need not go for zinc deficiency. It's only just 3 days,
Yes, sir.
Maybe lactose.
Can be lactose intolerant.
Right. See, the child will be definitely deficient of zinc, but it doesn't occur just after 2-3 days of diarrheal episode. But you have to consider the zinc deficiency very much. And what type of dermatosis their infections? No, you have something to show us dermatosis means. If you have an image that speaks 100 words, you have brought out all the images very nicely. Flexures. Dermatosis in flexures.
Not in flexus, sir.
Okay, no, previous slide you mentioned it. Okay, then. Well done. Right? Okay, we'll proceed.
Anthropometry.
So, assessment of growth by anthropometry. Our child is not photography. This is for reference.
What are the
And weight
scales
is
that they
measured
use?
with a digital balance. From digital and bathrobe scales.
Bathroom scales are not reliable. You have to go for the digital. Okay.
Yes, ma'am.
In this
Yes,
picture,
ma'am.
is it correctly measured? Infantometer is shown. Actually, we made this for OSCE of UGs. We asked them what is being measured, what to show what are the wrong things. So point out the wrong things.
Ma'am,
Please, somebody
the
tell-
headboard is
somebody
not
The
touching the head.
infantometer.
Headboard is not touching the head. Like head is not fixed, ma'am.
Hmm.
And
The assistant is
chin
holding the
not
child, not fixing the head
straight.
and keeping the chin straight. Okay. And what is the investigator doing? The examiner doing?
And the feet and
Yeah.
feet is not perpendicular to the board.
So this is, there are mistakes in this. So we have to show that. So this child, after what age you take height and up to what age you take the length?
After 2 years, we'll go for stadiometer, where all the bony prominence will be touching the wall, and the headboard will be touching the prominence, ma'am.
Okay.
And the Frankfurt plane should be in parallel to the horizontal, to the floor.
Okay. So show this child's anthropometry.
So coming to anthropometry.
Yeah.
No, Dr. Kirtana, to save time,
and
anthropometry is very
expected was
important. Very important. Just a minute. Anthropometry is very important. We'll have some more discussion in the later part because you are halfway in the slides. So we'll be reading it. You give us the analysis and inference. We'll read for ourselves to save time.
Okay, sir.
What's your inference?
Okay, sir.
Child is
So weight
You
for age
mentioned it.
was
mentioned
less
it.
than
What I want you to tell
minus-
is what could have caused underweight, what could have caused stunting, what could have caused severe wasting. What are all the contributing factors? I know it's undernutrition. What else could have caused this stunting, underweight, and wasting beyond undernutrition?
chronic malnutrition with this diarrhea precipitating.
You have written acute on chronic. Okay. Because both underweight and
Yes.
stunting
All
and
the
wasting.
three wasting was there.
The recent classification that WHO has proposed is like this: underweight and standard, standard and wasted, standard and obese, like that only. The SAM, MAM, all are going to history. Okay.
And so weight for age was showing severe underweight, and length for age implies mild moderate stunting. Weight for length showed severe wasting with head circumference was normal, and mid upper arm circumference was 11 centimeter, showing severe acute malnutrition. And the chronological age of the child was 15 months, but weight age was 4 months and height age was 9 months.
So
of
what
the 4
malnutrition is?
parameters, 5 parameters, which are the 2 parameters which have a lot of significance in a child with edematous SAM?
Weight for length and mid upper arm circumference, sir.
Very good, very good. These are the 2 things which have more relevance in a child with edematous undernutrition. Very good. See, you may be right in your history because the length is not very much affected comparatively. Probably the child would have been reasonably gaining weight, at least if not 9 months, for 6 months, when the
breast milk
was adequate. Right?
breast sufficiency
Your,
of breast milk is
parameter
there.
justifies your history. Right.
So all SAM will not have a mid upper arm circumference less than 11.5, but those with less than 11.5 are at high risk of dying. That's why WHO is still retaining it, even though arm circumference charts are there. So this child is meeting how many criteria for edema SAM or Kwashiorkor?
All the 3 criteria, ma'am.
Good. That is weight for
Weight for length less than 3 standard deviation.
spite of the edema,
bilateral-
there is wasting. Okay.
Yes.
Edema and mid upper arm circumference. One is
Circumference.
enough for making the diagnosis. Shall we go to the charts?
Just 1 minute, ma'am. Suppose the early infancy up to 6 months, to say SAM, what single criteria is sufficient? They need not have all the components of SAM. What is that?
Severe wasting, sir.
Pardon?
Visible severe wasting.
Severe wasting itself is sufficient to call it as SAM in an infant less than 6 months. Right.
In early growth failure and U6M under 6 months,
Under 6
how
months.
do,
Right.
how do we apply mid upper arm circumference? Can we apply
For
it below?
under, no, ma'am.
No. Early growth failure, the article you must read, which we wrote in Indian Pediatrics. WHO says that 6 weeks to 6 months, 11, less than 11 itself is one criteria
As for criteria.
for at risk, identifying at risk children. And when the length is less than 66 centimeters, the mid upper arm
11.
circumference cutoff is not 11.5,
Less than 11.
it is 11. Okay.
Now you would have taken the skin fold thickness also, at least for completion's sake. Okay?
Okay, sir.
Just for completion's sake, to make us more aware of the, where do you take the skin fold thickness? Just for completion. Where do you take the skin fold thickness?
Where all you will take skin fold thickness?
Behind scapula.
Okay. Right.
Under,
Okay, good enough. Proceed. Proceed.
Show the anthropometry charts.
wait for age.
Hmm.
The child will have a bone a weight age of 4 months.
Yeah. So if to know the normal, you should project it up to the vertically to the 0. And to get the
Yes.
weightage, you must project it horizontally to the 0. That is the green line. That is how the weightage is calculated. It is sometimes it is very good because in short stature and all, this becomes very important. We have to say chronological age and the relation to height age, bone age, developmental age, like that. Okay. So from this chart itself, we can know all these things. Next. So the child is severely underweight.
Yes, ma'am.
What
So
percentage
length for-
weight of this child may be contributed by edema? You said,
15 to 20%.
yeah, it is severe edema, gross edema, 20%. So 10 to 20% of the dry weight. Huh? Okay.
Yes.
Length,
Length is between -2 and -3 standard deviation, and the
so moderate.
length.
So it is
age
moderate.
is 9.
The malnutrition is, that baby is very young, no? As the age advances, the stunting may become more. And here the most important thing is that, okay, in weight, next chart, weight for length,
Weight for length less than 3 standard deviation.
and here the most important thing is that the weight for length chart starts with 45 centimeters. If the baby is less than 45 centimeters, then visible wasting is the only way. There is no chart. Okay. That's also an important point that you should know. Okay. Then head circumference.
And head circumference between -2 and -1 standard deviation.
Okay, at -2. And how do you measure head circumference?
So head circumference
Show that chart.
it's the occipitofrontal.
This was also taken for OSCE for UGs. What is the wrong thing that is being done? You tell the correct.
So it's occipitofrontal circumference, measuring the prominence of frontal prominence and occipital prominence, and it should have the overlapping should have been at the temple, overlapping of the tape.
Ma'am, you are with us?
Yes, sir.
Dr. Elizabeth. You are with us, ma'am? Or she lost the connectivity. Okay, probably she is out of the.
Yes, sir.
Next.
So arm circumference was
Yeah,
less than third
yeah,
standard deviation.
individual cases you may assess like this, but in Sam and ma'am, we will go for the cutoffs. How do you do the mid-upper arm circumference measurement?
I'm using a tape named as Shakers tape, which is a color-coded tape that is used for measuring mid-upper arm circumference. And the midway of between the acromion and olecranon process would be taken.
And at that time, how it should, which arm it should be taken? The
On a non-dominant hand.
And how is the hand held? Flexed at elbow first.
Yes, ma'am. While yes.
And
while measuring,
acromion and olecranon. And
olecranon.
Then midway you take. And at that time, the hand should be the hanging
extended
at ease.
Hanging push. Yes, ma'am.
And what are the cutoffs for this?
For less than 11.5 is severe malnutrition and less than 12.5 is moderate malnutrition.
Severe acute malnutrition. Ma'am is between 11.5 and 12.5.
12.5.
And normal is above 13.5.
13.5.
Okay. Shall we continue? Okay.
Yes, yes, still proceed, ma'am.
Yes. So I think we have exceeded the time.
No, that's why I'm a little hurrying a little.
Yeah.
Don't
Development is gross motor delay.
Was corresponding with the developmental history, ma'am.
Okay. Go. Continue.
So in a G examination,
what did you get?
Ma'am, hepatomegaly was present with a span of 7.5 centimeter.
How was the liver? Consistency?
Liver was soft in consistency and rounded borders, ma'am.
So suggestive of what? Is it Indian childhood cirrhosis or something else?
No, ma'am.
It is due to enlargement is due to collection of
fat. Fatty liver.
Fat,
no?
Yes.
And was there any ascites?
No.
No, ma'am.
So ascites is the last place to have the edema.
Last grade of
Kwashiorkor. Grade 4 only will have that. Okay.
Yes. Ascites.
Other systems?
Dr. Ketana,
respiratory system was
always start the GE examination from the oral cavity. Okay.
Yeah,
it's there. That I have already told in the general examination, but the convention it should be right from the end to this end. Okay. Right.
Yes,
if not the lower end, at least upper end. Here in the lower end also, you can speak about the anal excoriation. Of course, you already mentioned, but that looks sound.
Yes, sir.
Right.
Respiratory system?
Was normal, ma'am. Normal vesicular breath sounds were heard and no added sounds. And cardiovascular, apex beat was in fifth left intercostal space in mid-clavicular line, and S1, S2 was heard with no murmur.
So, where did you expect the apex beat,
I'm in fourth
fourth space. So
intercostal spaces.
what may be the reason for the mild cardiomegaly, if at all it is there?
Maybe due to anemia it can manifest. Then micronutrient deficiency like selenium,
Other nutritional cardiomyopathies.
thiamine.
Most of the micronutrients are now known to affect the heart. Vitamin D, thiamine,
Yes, ma'am.
selenium, okay, iron,
Yes, ma'am.
okay. So we call some of them as nutritional cardiomyopathy. And Dr. AP has answered thiamine. Yeah, thiamine is causing right heart failure, pulmonary hypertension, idiopathic pulmonary hypertension in breastfed babies when the mother is deficient. Okay. Next.
So nervous system, child was irritable and
Any
bulk
other?
of muscle was comparable with bilateral wasting, and power was 4/5 with
Severe
mild
wasting
hypotonia.
is there. Okay.
Yes.
Mild hypotonia. Can you get brisk reflexes in a child with malnutrition? Hypotonia, hypokalemia,
Yes.
hypotonia.
Yes,
Yes.
ma'am. Because pyramidal tract will be prominently involved.
Pyramidal tract is very vulnerable to
Anemia.
anemia. Okay. Next.
Suppose the reflexes are sluggish, especially lower limb reflexes. What's your take? Anybody? Other somebody come
Yeah.
help in answering. Suppose the reflexes are sluggish, knee as well as ankle. What's your take?
AD.
Somebody type in the chat box. Yes, it is seen. It is a nutritional myelopathy. It can. Okay. Next.
Coming to summary,
Dr.
summary
Ketra,
of
you
the
have.
examination.
I think
Dr. Ketra, there are 20
Yes, sir.
slides more. You may skip this. We followed you
Okay.
perfectly. Next. For want of time. Okay.
So, diagnosis of 15-month female child, third-degree consanguineous marriage, and sibling was sibling death at 2 years. The birth spacing of 11 months, and so diagnosis is severe acute malnutrition of edematous type of Kwashiorkor with severe underweight, moderate stunting, and moderate and severe wasting. MOAC of less than 11.5 centimeters, suggesting acute and chronic malnutrition, and multiple micronutrient deficiencies with nutritional dermatosis and hair changes, fatty liver and mild cardiomegaly, probably due to anemia or nutritional cardiomyopathy. And inadequate complementary feeding that is not meeting the IVCF practices, and with acute diarrheal disease and some dehydration.
This is more like summary rather than clinical diagnosis. In clinical diagnosis, you need not mention about the anthropometric parameters, and you need not mention about the findings like which are inherent or components of the severe acute malnutrition. Okay, right. No, you have done a comprehensive summary, but right. Next.
So we'll
So-
quickly go through any differential diagnosis, investigation, and management.
Yes, ma'am.
So what else is in your mind?
So,
it is
uh,
there is malnutrition and certain complications, accompaniments of that. Then the current illness with which the child reported is the acute diarrheal disease with some dehydration. Okay.
Yes.
What else you want to consider or keep in mind when you investigate? Yeah, tell. So you
celiac
want-
disease.
Celiac
Sorry,
will
ma'am.
be there only for 2-3 days, and it usually starts when wheat is introduced. No, the baby was tolerating the wheat right from 6 months, and it's when gluten is there, they frequently give it, and it will be almost a chronic problem. Okay. So you were thinking of immunodeficiency due to the other thing you said, sibling death is there, similar illness is there. So how will you
Can be nutritional.
differentiate nutritionally acquired immunodeficiency syndrome with the HIV/AIDS? Both are said to mimic
and- Yes, ma'am.
more of
In HIV, there will be lymphadenopathy.
very good. Usually there will be lymphadenopathy, which will be absent in the malnutrition, plus gamma globulin fraction. What will happen?
Will be high in HIV.
Due to opportunistic,
Increased in
so much of opportunistic infection, whereas it may be on the lower side in the malnutrition. Okay, in malnutrition.
malnutrition. Okay.
Which IgA deficiency you are thinking of? What are the types of IgA deficiency? By far, that is very common immunodeficiency, which usually we miss. It can be transient also, because IgA may take some time to mature in some children. We have seen children branded as IgA deficiency with diarrhea, then getting over all that after, say, 4 or 5 years. So it can be IgA deficiency, can also be transient. And mostly they present with pneumonia and diarrhea.
Right.
Yes, shall we go to
Yes,
any
ma'am.
other
Just
differential
just 2 minutes.
diagnosis?
2 minutes. Your comments, Professor Srinivasan. Professor Srinivasan of JIPMER.
Listening and learning. So no comments from me.
Do you want to add anything, sir?
Yeah. I am enjoying and learning a lot of things.
I acknowledge the presence of Professor Vijay Lakshmi, Professor Tirupati Reddy, and some 3-4 are there. Dr. Alok Gupta. They may give their impressions just in 2-3 sentences, for want of time, not to hurt you. Right. Okay.
Yeah,
Dr.
the rest
Dr.
are-
Balasubramanian, your comments on physical examination.
we were little
Very,
hurrying.
very well discussed. Few comments. Actually, one question to the student. What are the peculiarities with regard to dehydration in infants and children with severe acute malnutrition? Peculiarities and difficulties for the clinician with regard to diarrheal dehydration in severe acute malnutrition compared to normal children.
So there can already be a sunken eyes. So with that, we cannot differentiate. And skin turgidity.
No, you tell what
Cannot
are
be
the
reliable.
reliable factors. Dr. Ketana, on which factors we can rely? You tell that way.
Yes, sir. Decrease urine output and thirst
Then what
might
else?
be reliable.
What else?
Okay, this is exactly the answer I wanted you to say so that I can correct you. Urine output is not a reliable sign, very similar to your skin turgor. Skin turgor and urine output are not reliable signs, reliable parameters for assessment of dehydration. I'll tell you, in fact, history, Professor Srinivasan would have read in the 9th edition, 8th edition of Nelson's textbook of pediatrics, the chapter on malnutrition and diarrhea was written by Professor S.T. Achar. I still remember reading what I read. Children with severe acute malnutrition or chronic malnutrition, because they lack protein in the blood, their creatinine levels are low, they fail to concentrate the urine in the tubules. they'll be passing usual quantities of urine even in the presence of dehydration. They'll be passing dilute colorless urine. So you cannot go by urine output, number one. Number two, of course, many of them don't even sweat properly, right? Because of the lack of collagen and protein in the skin and underlying tissue. Third, even if they cry, tears will not come. Fourth, skin turgor is very, very unreliable. Fifth, in the presence of edema, it's always very difficult to assess dehydration. So you have to go by weight. You have to go by the eyes. You have to go by the weight. And you have to go by the pulse rate and blood pressure.
Sir is telling the pulse is the most sensitive indicator
Yeah.
of
Yeah.
depletion in
Yeah.
the
Yeah.
intravascular volume. In any scenario, it is
Okay.
the most sensitive indicator
Yeah.
for intravascular volume
Yeah.
depletion. So that is the most reliable
Yeah.
here also. What?
And
in
also
next-
quantifying the output, watery diarrhea. So much of loss is there. The loss can be assessed.
Okay, ma'am, that's got it. Another point, right? See,
Yeah.
extension to that, to what was discussed. See, we have to be very careful in administering IV fluids in a child with a same child with shock. It cannot be heroic, and you have to be very cautious lest the child may go into failure and cardiac, because the heart will not be able to handle even a little bit of overload. Okay, you have to be very cautious, and generally that is not done by the boluses. So we don't give boluses even if there is shock in child with SAM, right? We will go directly with infusion, right? We will see. And
Yeah.
just forget, and this is the only scenario. See, generally resuscitation fluid shall not contain dextrose. Repeat, in any scenario, resuscitation fluid shall not contain dextrose. This is one caveat where the resuscitation fluid shall contain dextrose, either in the form of half NS plus dextrose, or Ringer lactate plus dextrose, or Darrow's plus dextrose. Okay, this is the only scenario where you give dextrose in the resuscitation itself, and prior to that, you give turnus of dextrose also. Ideally, orally, if not nasogastric, both are not possible, IVR, right? This is the some exception scenarios, how the child with SAM shock will be resuscitated. Yes, sir. We'll go ahead.
Yeah, one more comment. These children are more prone for hyponatremia, dehydration, much more than hypernatremia or isonatremia, dehydration. Hypokalemia is much more common in severe acute malnutrition than in well-nourished children. Because again, they fail to reabsorb the potassium in the tubules because of lack of creatinine and lack of urea, right? And you must be careful in not overloading the circulation and producing cardiac failure when you rehydrate. The other comment I wanted to make is that sometimes you can get a combination of more than one factor operating. For example, Madam was mentioning about, I'm going to ask Kirtana, which is the most common immunodeficiency in the world? Which is the type of immunodeficiency, the most common one? Any
So-
PG can put in the chat box. The most common immunodeficiency in the world.
More so in
Right.
underdeveloped
Quiet,
countries.
sir.
Or inborn error of immunity, the modern term. No, somebody has put hyper IgE, I'm wrong.
No. Communist.
Most common. It's a quiz question. It is IgA deficiency. IgA deficiency is the most common immunodeficiency, and majority of IgA deficiencies need not be symptomatic. Prognosis is extremely good. Okay. The only problem is a few children with immunodeficiency who have IgA deficiency may manifest, and few of them may manifest in later age group at 10 years as common variable immunodeficiency. What is initially diagnosed as IgA deficiency may turn out into common variable immunodeficiency in older age group. Okay. An IgA deficiency as a cause of severe acute malnutrition is rather uncommon. The most common immunodeficiency which causes SAM is T cell defect followed by B cell defect. And the other important point you must remember, this child who has started manifesting a little later than usual, beyond 6 months, is more likely to have a humoral immunodeficiency, unlike an infant who presents at 2 or 3 months, who is likely to have a T cell immunodeficiency. Thank you. Well presented. Well discussed, of course, by Professor Elizabeth and Professor Ramakrishna.
Thank you, sir.
Thank you, sir. Right. Dr. Ketana, just proceed.
Yes, sir.
Right.
It's very late now. Can we
But,
continue?
he prepared so many slides. She will run through them. Okay.
So
Dr.
these are the
Ketana,
investigations.
No, only important things you tell.
Okay.
No, what is to be done, Kadu? What is abnormal in this child? If at all you have done, right?
Yeah, that results have not been entered. So what
Okay.
was abnormal? What was the hemoglobin?
Yes, ma'am. Yes.
What was the hemoglobin and what type of anemia the child
The
had?
child had a hemoglobin of 7, ma'am.
Which is severe
Yes.
anemia at this age. And it
He
was
had anemia.
what type
Severe
of
anemia.
anemia the child had? Normocytic, megaloblastic, microcytic,
And
suggestive of iron
hypochromic
microcytic
microcytic anemia, ma'am.
anemia.
Iron deficiency.
There are at least 5 types of microcytic hypochromic anemia. How do you conclude that it is iron deficiency? Which
Since
component in CBC will tell you that it is? MCV is low, MCH is
red
low.
cell indices.
No,
And
that's
what will be high? What will be high? It is the RDW. The anisocytosis. RDW will be high. And can be substantiated with the peripheral smear. We can look for abnormal cells, parasites also. Okay. In blood sugar, you already said the child did not have hypoglycemia. RFT, what was significant? Blood urea was? Serum
Blood
creatinine.
urea and creatinine, because it can depict muscle wasting, serum urine.
Creatinine was very low. Okay.
Ma'am, we will do something, ma'am, Professor Elizabeth. We will go to, if there is nothing very specific in investigations, we will go for management, outlines of management.
Yeah, outline the management.
More important than investigations, I believe.
I think now these are all next all are teaching slides, so she can just read through. Right. Okay. Next. So
next.
We want to apply the 10 steps of SAM.
10 steps of the WHO.
So hypoglycemia prevention, hypothermia prevention. Now dehydration. So this child had dehydration. So I think skipping all the rest, we will go to dehydration. What is the difference in the hydration? How the hydration will be different in a normal child versus the SAM child? So tell us. You have the slide.
In a normal child, yes, ma'am.
Slide. Speak
this
with the
is a slide. For a normal child, so some dehydration, 75 ml per kg. ORS will be over 4 hours.
Here, how do you hydrate? And what ORS you will take?
Risomar, ma'am, rehydration solution for.
But it is not available, so
we can prepare by a modified ORS can be prepared.
So you must say Risomal or modified ORS should be given. Okay. And how much quantity? How will you give it?
1 packet in, you have to put 1 packet in 2 liter water with 50 grams of glucose and approximately 40.
Then take 1 liter of that and add glucose and potassium so that the sodium comes down, the glucose goes up and the potassium also goes up. Okay. And how do you cautiously hydrate the child?
So I have to record the weight and then 5 ml per kg ORS is given every 30 minutes for 2 hours.
And so it is
then again
at the end of 2 hours you would have given
the
20
weight is gaining
Hmm.
20 ml per kg, ma'am.
So in 4 hours,
And
in 2
if the-
hours, you gave only 20 ml per kg. Whereas the other one, 75 ml is given over 4 hours.
At
And then
75.
suppose the
Uh,
baby is losing weight and there is still watery diarrhea is going on, you can give
10 ml per kg. You can increase ORS to 10 ml per kg.
increase to 10 ml per kg in 30 minutes. And the hydration is done
Yes.
in 4 hours in a normal child. Here it is
Normal
done
child
over,
and over 12 hours.
this is
12
over.
hours in total, ma'am.
Okay. So it is very slowly done and the ORS should be modified so that
Yes,
the
ma'am.
sodium is less and the potassium and the glucose are more. Okay, continue. Suppose it was a shock or severe dehydration. Child was in shock, unable to drink. Then the IV fluid, what is it? What is the difference that you have to make? Okay, go to
We
that.
have to RL with 5% dextrose or N/2 with
So
5%
half will be
dextrose.
normal saline, half will be what? 5% in
10%
RL in 5%
dextrose.
dextrose means half should be 10%. Then the
Yes,
total
ma'am.
will be 5%. If you take 5% half,
At
it will be, the total solution will be 2.5. Okay, only. And we give it over 1 hour.
At 15 to
The
15
1
ml per
hour,
kg.
the 1 hour
per hour
fluid
for
in
first.
a normal child will be 30 ml is the first
30.
rate. Here it is only 15 ml per kg.
15.
That is the difference. And we have to make it half normal saline or half ringer lactate. And the rest half should be 10% glucose so that the
Dextrose.
total solution will be 5%. Okay. Go to
And I
next.
have to monitor for every 5.
How will you identify fluid overload? That is a major problem that you have to identify.
If there is the respiratory rate is more than 5 or pulse rate more than
So
15.
we
or
will
there
be
is
ordering
grinding
for 30 minutes. Every 30 minutes, you will have to
or
assess. Okay. Increase in?
And there is liver size by 2 centimeter. There will be lung crepitations or grunting, and with triple rhythm is 3.
No,
So
go
these
to the
are-
previous slide. It seems it's good. Previous slide. Previous. No, you are going to next.
The
Previous.
IV fluid. The
Yes,
IV
sir.
fluid.
No,
The IV
that's not.
fluid.
There is one slide that is gold. No, this one only. Next one. Next.
Actually,
That is slide 50.
Sir, severe dehydration.
Slide 50.
Yes, sir.
it is same, almost the same.
That's it. That's a nice slide. You have brought up nicely. Right.
Okay. And then severe anemia. So this child's
child-
another problem is severe anemia.
Anemia.
So what is the management of severe anemia in a SAM case?
So if it presents on day 1 with more than 4 grams percentage hemoglobin or PCV more than 12%,
No acute treatment is
or
required. No
yes,
PAX.
ma'am, non-acute treatment is required.
Paxil is
And
given
it's
only when
when it presents on day 1 with hemoglobin less than 4 gram percentage or Paxil less than 12%.
Then 10 ml per kg of Paxil can be given. Because
Paxil is
on
given.
second day onwards, the edema fluid will be coming to the system. That is why we say that we cannot give overload with packed red cells, etc. We will wait for stabilization and then only the iron will be started. Okay. Go to next slide.
So,
Next slide.
micronutrient deficiency.
So when will you give day 1, day 2, and day 14 vitamin A?
If there is deficiency,
So in this child, will you give?
signs.
Will you give?
Yes, ma'am. He had conjunctival cirrhosis. She
Ah.
had.
But when Kwashiorkor state is there, if there is a danger of keratomalacia, we will be giving the
Or
not the water soluble form only we will give, because the
Okay.
liver cannot handle all the load. But Aquasol A, that is the preparation of injectable, it is soluble in aqua. So it will correct the morbidity, but it will not cause storage. So once the Kwashiorkor state edema goes down, we will be giving. And see that the child did not get vitamin A in high dose in the last 1 month. And
Okay.
2 lakhs should be given. This child, will you give 2 lakhs or 1 lakh?
2 lakh. No, ma'am, 1 lakh because the weight is less than 8.
Even though the child is more than 1 year, the weight is less than 8 kg. So we give only 1 lakh. And
1 lakh.
zinc, copper, folic acid, multivitamins should be given till what time? Till recovery.
Till
That may take 3 to
rehabilitation.
6 weeks. Similarly, potassium, magnesium, etc. And iron will be started in the after stabilization. Severe anemia, what is the dose of iron?
3 mg per kg per day.
Yeah, previously it was 3 to 6. Now we give 3 mg according to the Anemia Mukt Bharat, because unabsorbed iron in the gut can cause E. coli to thrive and there can be free radical damage. Okay. Next.
So cautious
Feeding.
Cautious feeding.
Hmm.
So milk-based formulas of F75 will be started, starting with 100 ml per kg per day in edematous SAM. If there is no edema, you can start with 130 ml per kg per day. And breastfeeding should be continued, and the frequency should be gradually increased in risk of heart failure.
So we start with
First
2 hours, almost 10 or 11 ml per kg, and we can reach up to 22 ml per kg. Okay. And once the baby is stabilized, the appetite is good, edema is losing, we will shift to F100.
Ready to
F100 and RUTF. And what is the equation between 100 ml of F100 and RUTF? How much RUTF can replace? Alternate feed can be replaced because the child would like to eat also, no, not drink only.
Yes, ma'am.
So 20 gram of RUTF can replace 100 ml of F100. So the baby is on 100 ml F100 every 4 hourly. Then we can give alternate feed can be RUTF. Okay, next. How will you make? What are the 2 types of F75 and F100? Then go to next slide.
Cereal based and non-cereal based.
No, milk based and cereal based.
Milk based.
So any baby more than 6 months can go for the cereal based, which is more tasty and more acceptable than the milk based alone. Some babies vomit the sugar and the oil and all. Always we give the same diet. And the normal, nobody should eat the normal like idli sambar or roti, etc. with curry and all in front of the child, because sodium potassium pump has failed in them. So initially only this is being recommended. And how do you do appetite test? How do you do appetite test? Go to the next slide.
For classifying whether the child needs a community management or IP care, we give a 30 grams here according to weight. We give
1 teaspoon per kg. So this child is 6 kg. So 6 into 5, 30 gram is given. And the mother and the baby should be given a decent place to, quiet place to sit and feed the baby. And if the baby takes most of it, 80% of it. The baby has passed the appetite test and the baby can go to the
Appetite test.
rehabilitation phase. Okay. What is RUSF?
Ready to use supplementary food.
Which is indigenously prepared. The RUTF is patented
Indigenous.
product. It has this, energy, protein, and fortified with micronutrients. But at our level, we cannot fortify. We give all the micronutrients separate. But we match the energy and the protein. Cereal pulse plus skimmed milk powder plus coconut oil. Why coconut oil specifically I am telling? Because I am from Kerala. We are from Kerala, I am telling. Or is there any
Middle chain.
reason? It is a medium chain
Triglyceride.
triglyceride. Even if there is some
Triglyceride.
fat malabsorption, that will be absorbed into the straight into the portal vein. Next slide. And the next slide. Next slide. So what is this?
Tick
The
sign.
tick sign.
There will be an initial
Is it
loss of
good?
weight.
Our child
Yes,
had
ma'am.
similar picture. So what is it good for the child or bad for the child? The child is losing weight.
For the child.
Why? What is
During
the
the
losing?
initial,
Edema
there will be initial weight loss.
Edema fluid. Will
Loss
be,
of edema fluid, ma'am.
and the child will
During
come to,
treatment.
this is actually a marasmic Kwashiorkor, no? Because severe wasting is there. So the baby should, from the
Yes, ma'am.
Kwashiorkor state, the baby should come to a marasmus state. And marasmus is much more easier to treat,
Marasmus.
and then the appetite will be good also in the marasmus at that stage. Okay. So this is tick sign is a good sign of recovery. Okay. So we start with 100 kilocalories and 1 gram, 0.9 or 1 gram protein and 100 ml per kg. And where do we reach? What is our final target for complete catch-up growth? It will be 200 ml of F100. That means 200 ml per kg, 200 kilocalories and 6 gram protein.
Yes.
So we start with 1
6
gram
grams
protein and reach 6 gram protein. We start with 100 ml and we reach 200 ml. We start with 100 kilocalories and reach 200 kilocalories. Okay. Next slide. How will you treat MAM? That is also one slide is there. MAM is treated with
again 150 kilocalorie per kg per day
Hmm.
of calories and 3 gram protein. Can be given by ready-to-use supplementary feed or ensure double ration of take-home food from Anganwadis for children with MAM and SAM.
Okay.
With SAM without complication.
Okay, next slide.
So monitoring. So a good weight gain is said when there is more than 10 grams per kg per day weight gain.
So this is after
And
reaching the trough weight of edema-free weight. Trough
Yes,
weight
ma'am.
the baby should reach. From there, the baby has to gain weight. 10 gram per kg per day is very good. Okay. 5 to 10 is moderate and less than 5 is poor weight gain. Some
weight
hidden infections we have to think of. And when can you discharge the child from the program?
When there is no edema for 2 weeks, or when the weight for length reaches -2 standard deviation.
That is discharge from the hospital. Discharge from the
program
and, is when the weight for height is more than
height reaches 90%
or 1 set score. That is the road to plus -1 to +1 is road to health. The green zone the baby will reach. Okay. Next slide. So who is fit for going CMAM? What is CMAM? You started telling that, but I did not. Community management of acute malnutrition. So previously all SAM had to be admitted, now only with medical complications. And refeeding syndrome is a OSCE station usually, and it happens what time of the phase of treatment and why?
On
what
about
is physiology?
fourth day. On about fourth day, refeedings occurs due to switch from catabolism to anabolism.
So the baby shifts from
Uh,
catabolic state to anabolic state. And which hormone
and there
is
will be
affecting?
increased insulin secretion.
So during
Insulin, ma'am.
the
Insulin will be increased
catabolic
and
state, insulin will be very low. Now that we are feeding sugar-based formula, lot of insulin will be secreted. And what will the insulin do? What will insulin do?
it will cause uptake of potash, causes uptake of the nutrients, thiamine, potassium, phosphate, glucose
Into the cell. And so there will
into the
be.
cell.
So what will happen?
Hypomagnesemia, hypokalemia in the cell, in the blood.
Hypophosphatemia, and that can be
Hypokalemia.
potentially fatal also. Okay.
Yes.
Next. So suppose this baby has lactose intolerance. How will
Yes,
you
ma'am.
modify the diet of the child? Persistent diarrhea and lactose intolerance.
So initially a low lactose diet will be tried on for 7 days, and then no lactose diet, a lactose free diet, or in the
Second will be lactose and sucrose free. And the next will be lactose, sucrose and starch free. There we go for the monosaccharide based diet. So suppose the baby is having this problem. And what is amylase resistant starch, which is good for diarrhea? ARF. That is, certain food will go undigested into the colon and will be fermented into short chain fatty acids only. But that is very good for the colon, and it is also very important in the gut brain axis also. They are the green banana, sweet potato, cooked and cooled starch, which is very popular in Kerala also. The banana powder is very commonly given during diarrhea. I think that is the last slide. So over to experts for comments. Ramakrishna sir.
Yes, it's a really wonderful presentation, and I need not tell anybody's knowledge that Professor Elizabeth will excel. So nothing very special to mention even. You lived up to your standard span, and the last 15-20 slides, I didn't expect that good, and I just like, because she prepared, I wanted her to complete, but they proved to be very good for the exam going students also, right? See, the initial slides are also good, but these 15-20 slides, they are very much useful for writing their theory examination. Well done, madam. It's very comprehensive management. And Dr. Ketana, you did a good job, and well mentored by your professor. And comments from seniors, Dr. Srinivasan, Dr. Bala, Dr. Alok Gupta.
You can stop the slide share.
I learned a lot today from all the comments as well as from both of you. Okay, so I will reread your book again. Thank you.
That is the spirit of learning, right, sir?
It was a long learning.
Excellent
Thank you, ma'am.
case and presentation. Wonderful moderation, ma'am. And yes, I always in every child counsel the family for the vaccination. The case as well as other SIBs and whatever adult vaccinations can be done as per the economic status of the child. Yes, the government vaccines should be taken, and as soon as possible. They're more important when malnourishment is there. So low birth weight and all these children, even if birth, should not be denied or the vaccine be delayed. So all age appropriate vaccines should be there, and if by any chance there is a outbreak of measles or something of that sort, we can even give the measles vaccine a bit earlier to prevent that in the child. It is now in the recommendation that we can give it anytime after 6 months in case of outbreak and the child is susceptible. So we can do that.
But don't count it. We'll have to give at 9 months again.
Yes, definitely.
And
Definitely.
post-exposure also.
Right.
Post-exposure prophylaxis.
So prevention of infection is also as important as reapplication of nutritional rehab. So that is my take. Thank you.
Thank you.
Right. Now it's the turn of some 2-3 postgraduates to unmute and either ask the question or any requests from the mentor or your opinion. It is your program. I want at least 2-3 postgraduates to unmute and speak. Either a query or a comment. Be
It's so
proactive, I
long
say.
that they are all overloaded.
All the elderly people are active. Why not they? Right. Okay. We'll call it a day. Thank you very much, Madam Professor Elizabeth. Well done by Dr. Kirtana. I thank Dr. Balasubramanian, Dr. Sadgopan Srinivasan, and Dr. Alok Gupta.
Srinivasan didn't have anything except learning.
See, learning is the best way of enlightening also. Right. You are standing as a role model. Right. And all the professors who joined, Dr. Vijayalakshmi, Dr. Tirupati Reddy, and others. And right. And wish you all the best, Dr. Kirtana, and I wish all the best for all the postgraduates who have joined, and good health for all the elders. We'll say good night.
Good night.
Good night, and thank you so much.
Thank you. Good night.
Thank you. Thank you, ma'am.